And as far as the pathophysiology, the thought is, and you update me because it's been a little while since I've gone down that road, but the patients, as you mentioned, over 90% of the population has had an HPV infection, has been exposed to the virus, but their immune system has cleared it. And potentially there's a subset of patients who are keeping it at bay, but it's not totally cleared. And then something happens over time and it kind of rears up.
That's exactly right. I couldn't have said any better. And so that's what happens. It essentially, let's just call it a chronic infection that integrates, or in the way I tell patients or talk to patients about it, I basically say, well, the virus is just trying to replicate. It's trying to create more of itself. It gets into that tonsil, and then all of a sudden it is now replicating squamous cells. And that is essentially what happens.
Yeah. And we don't necessarily know what the, trigger changeover point is, right?
Not yet.
Yeah. Working on it.
You're working on it. There's some really interesting science behind that. And I remember asking our collaborators. And so we, again, because we're at academic center, we have a number of collaborators. And one is Rafi Ahmed at the Vaccine Center, and Andreas Wieland, who was there at the time, but now is at The Ohio State. I asked them this question. It's like, we really haven't been able to figure this out? We still haven't.
Yeah. And that probably means there's more than one, thing that's happening. And so it's just too hard to pin it on one culprit. So the HPV squamous cell cancers are usually in the tonsil or base of tongue. So oropharynx is that primary subsite. Why is that the primary site and not larynx or hypopharynx or somewhere else in the head and neck?
This was a source of debate for some time because there were times when cancers from the tongue or the larynx were removed, and they have P16 positivity, which was considered at that time a surrogate marker for HPV. But if you ask HPV researchers, they're going to say it can't just be P16 positive. We need to know that there's HPV DNA in that specimen, and we need to look at in situ hybridization. So there's got to be really three ways to look at it to determine if it's truly HPV-driven. And when you distill it down, we've come to realize that there's just something about the tonsil and the tongue base, specifically that histologically they're different. They are lymphoid tissue. So primarily, it's an immune-rich environment where you would think a virus would like to want to be. And what causes all of the quick spread, so to speak, is that there's really no basement membrane in those areas. And that's why we often see a small cancer there, but that's not how they're noticed.
Yeah. Yeah, which is a good segue into kind of the typical presentation for these patients.
Uniformly, I feel like it happens after some stressful and whatever it may be. Oh, I was going through some business thing or closing, or I was sick for a little bit, and all of a sudden I had this knot that I noticed in my neck when I was shaving. Got some antibiotics for a little bit because you thought it might be infection. Got a CT scan. Got a fine needle aspiration of that node, and I can't believe I have cancer. That's usually what I hear.
Yeah, and that's kind of where you probably meet patients most of the time, since you're kind of the tertiary referral center.
Yes, that's exactly when I see them. It's at that point, and then results in a kind of long discussion about treatment options, and what to do next.
Yeah, and finding the primary,